Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be on the CT evaluation of pulmonary artery aneurysms. Now, we do talk about the pulmonary arteries a lot in CT, but most of the time we're talking about is there or is there not a pulmonary embolism present. We look at the pulmonary arteries also in patients with lung cancer. Occasionally, tumors can encase and narrow the pulmonary arteries. We also, at Case Conference, talk about rare pulmonary artery tumors like primary sarcomas of the pulmonary artery. But we don't speak that much about pulmonary artery aneurysms because the reality is they're fairly uncommon. They can be somewhat tricky to diagnose. And what we're going to do over probably 2 lectures is look carefully at this topic, look at a number of examples, look at the key imaging perspectives, look at the key clinical perspectives, and try to learn more about them. Now, of course, first of all, pulmonary artery, the main PA has a normal diameter up to 28 millimeters in adults. We talk about looking at the right and left pulmonary arteries, which are typically of equal diameter. When one is significantly larger than the other, then we're talking about pulmonary artery dilatation or maybe an aneurysm. And these aneurysms can occur in the main pulmonary artery, in the right or left main pulmonary vessels, or in any of the branches. Now we talk about the anatomy. Right and left PA divided into 2 lobar branches at the high-low level. The right PA passes anterior to the right mainstem bronchus and divides into the truncus anterior and the interlobar artery. And we talk about these branching. Left PA courses superior to the left mainstem bronchus and divides into the left upper lobe artery and left interlobar artery. Now, it's important to understand the branching, and I won't go into it in any more detail, but the times you really need to think about that is when you're following the pulmonary arteries and looking for the presence of pulmonary emboli. So again, we talk about branching. One of the things, the questions with PE is often, is it a subsegmental artery? So this description by Cortopassi, the segmental pulmonary arteries to each lobe travel with an accompanying branch of the bronchial tree and are named accordingly. Once the segmental arteries divide, they are then considered subsegmental arteries. And of course, we can have pulmonary embolism in the main pulmonary artery or in any of the branches. In this article by Nugent, although pulmonary artery aneurysms and pseudoaneurysms are uncommon, knowledge of their congenital and acquired causes and radiologic manifestations is important. Assessment with contrast-enhanced CT allows the accurate evaluation of pulmonary artery aneurysms and pseudoaneurysms, facilitating prompt diagnosis and treatment. And again, complications of these aneurysms and pseudoaneurysms can be rupture and bleed, so the early diagnosis indeed becomes very, very important. Now, when you talk about pulmonary artery aneurysms and pseudoaneurysm, an aneurysm is a focal dilatation containing all 3 layers of the arterial wall, while pseudoaneurysms are missing 1 or 2 of these layers. We talk about causes of pulmonary artery aneurysms and pseudoaneurysms. There can be cardiovascular anomalies such as PDA, can be infectious processes, neoplasm, trauma, and even vasculitis, as well as pulmonary hypertension. Pulmonary artery aneurysms are often discovered incidentally, but can present as hemoptysis or can present as rupture. It's rare, but again, as we said at the beginning, it's an important diagnosis. Here's a nice example of a pulmonary artery aneurysm of the left main pulmonary artery. Again, there's a bulge and a bump. It's easy to diagnose. Here's a similar example from an article I'll show you a bit later. But here's the bulging. There it is again. And that's a pulmonary artery aneurysm, nicely shown on CT. Here's a pulmonary artery aneurysm that involves the main pulmonary artery. Look at the size, it's almost twice normal. The branching to right and left pulmonary arteries are seen. They're not involved. It's the main pulmonary artery that's involved in this case. And just a really nice example, here it is on the volume rendered coronal views, and here it is with volume rendering in the sagittal view. And you can see how large the aneurysm can be, and of course at this size the potential for rupture or other complications is indeed of great concern. On the flip side, pulmonary artery aneurysms can be small. Here's a pulmonary artery aneurysm, right lower lung. Now, one of the things you remember from reading chest x-rays, every once in a while you see a nodule very well defined and it looks like a vessel's going to it, and the differential between a nodule with maybe a feeding vessel or a pulmonary artery aneurysm is considered. CT was the gold standard and is the gold standard for proving which one of these is true. Same case, just a few different images to make the point that coronal can be helpful. You can see it nicely, but also talking about MIP imaging. When you look at the pulmonary arteries, we do lots of cases looking for pulmonary AV malformations. That may be one of the things you want to look at. MIP imaging can be very valuable in that regard. Here's a few more MIP images showing you the pulmonary artery aneurysm in the 1 centimeter range to the right lower lung. And here is the cinematic rendered image. 2 different renderings nicely showing you the vessel and then the pulmonary artery aneurysm about 1 centimeter in size. In the article by Nugent, an aneurysm is a focal dilatation involving all 3 layers, as we said. The upper limit of normal diameter of the main pulmonary artery, 28 or 29 millimeters, and the right interlobar is 17 millimeters. We define aneurysms as focal dilatation beyond the maximum normal caliber. So again, measurements become very important. The measurements can be done with the MIP imaging, can be done with volume rendering, or just off the routine axial and coronal views. I mentioned this before, but I'll mention it again, that pulmonary artery aneurysms and pseudoaneurysms are uncommon, but there are a range of possibilities from trauma to vasculitis to unusual causes from congenital heart disease to connective tissue disease. Again, regardless of the cause, the diagnosis indeed becomes very, very important. Now, we do also see at times in many vessels, but including the pulmonary arteries, the possibility of mycotic aneurysms. We talk about mycotic aneurysms often secondary to endocarditis with septic emboli. A Rasmussen aneurysm is one of the things to think about. It's a subtype of mycotic aneurysms where a cavitary lesion caused by TB weakens the adjacent pulmonary artery wall, resulting in this aneurysm. So again, becomes very, very important. Again, with mycotic aneurysms, they're not all that common. We talk about them in IV drug abuse. We talk about them in the groin areas where there is IV drug abuse, the region in the elbow, again, the groin. But it can be a range of possibilities. Chest x-rays can suggest the diagnosis of a nodule within a cavity and a rapidly growing mass. And then with CT, you confirm that it's a pulmonary artery aneurysm. I mentioned vasculitis as a possibility. The most common vasculitis associated with pulmonary artery aneurysms are Behçet's and Stauven syndrome. Behçet's is characterized by vasculitis with recurrent oral and genital ulcers and uveitis. It's most commonly seen in Turkey and Southeast Asia. We see Behçet's every once in a while, not only with pulmonary artery aneurysms, but also with bowel involvement. One of the things about Behçet's disease These pulmonary artery aneurysms may regress with immunosuppressive medication, but usually embolism is necessary to really prevent the complications of rupture with hemoptysis. We talk about pulmonary artery aneurysms or pseudoaneurysms, that they can be iatrogenic due to right heart catheterization and pulmonary artery catheter placement, but this remains very rare. Pulmonary artery aneurysm formation, again, carries a poor prognosis with a 30% mortality within 2 years of diagnosis if left untreated. So again, one of the key things is treatment, and this includes embolization. It includes surgical technique, including lobectomy, pneumonectomy, and aneurysm resection. And a very good article by Corpasi, which I've quoted a few times, really does this. The idea about Swan-Ganz catheters as a cause of pulmonary artery pseudoaneurysms is something that occurs infrequently, but in the differential diagnosis of complications, when you start seeing an enlarging mass involving the pulmonary artery, you have to think about that. The tip of the catheter erodes the vessel, causing weakening and dilatation, and it then can rupture with all of the potential complications. We also talk about some of the connective tissue diseases, Marfan's, Ehlers-Danlos, cystic medial necrosis, all can yield aneurysm formation in multiple vessels, including the pulmonary arteries. We talk about other things. I mentioned Behçet's. We mentioned other things that in terms of different types of systemic inflammatory disorders. So again, one of the things we don't often think about with some of the vasculitis and some of these other conditions, which are indeed rare, is pulmonary artery aneurysms. But again, perhaps when you're looking at the CT, we're often getting CT to look at the aorta, and these patients look very carefully as well at the pulmonary arteries. Now, we published an article. This is actually still in press. Yasrub did a great job, CT imaging of pulmonary artery aneurysms in the emergency department, what you need to know. And we looked at many things. They're rare vascular abnormalities, as I mentioned before. And we also talked about the importance of post-processing, including volume rendering and cinematic rendering, as a way of being able to detect and define these aneurysms and pseudoaneurysms. Again, we mentioned some of the articles we reviewed, a very low frequency, 0.007, according to classic autopsy series. We talked about the fact that true PA aneurysms involve all three layers, while pseudoaneurysms involve one or two layers. And because of that, the pseudoaneurysms are more likely to rupture. And from our article, here's a nice example of what looks like a nodule at first glance in the left lower lung. And you can see on the MIP and the volume rendering that 1 centimeter structure is actually a pseudoaneurysm. You can see it here as well, very nicely showing you the patient's pseudoaneurysm. Again, it looks like a nodule, but it's enhancing. So you got to be thinking about that possibility. Here it is, left lower lung, nicely shown on the MIP imaging. A few rotations in the MIP imaging showing this to you very nicely. And again, on the image on the right, volume rendering, image on the left with MIP imaging. And again, just the extent. One of the things important when you see a pulmonary artery aneurysm, a pseudoaneurysm, to look for additional abnormalities. Most cases usually are solitary, but because of the conditions like vasculitis, you need to think about multiple pseudoaneurysms or aneurysms being present. And this case very nicely shows you there's only one lesion present, despite the fact that I use lots of MIP imaging, some volume rendering, and scroll through the volume very carefully. And again, nicely shown with cinematic rendering. So again, the ability to use all of your tools in the evaluation of these patients becomes very, very important. Now, in this article, we spoke about many of the different possibilities for pulmonary artery aneurysms, idiopathic, associated with various conditions. We mentioned some of these before, from connective tissue disorders to neoplastic disease, IV drug abuse, lots of different possibilities. We talk about the symptoms, hemoptysis, cough, dyspnea, are all going to be possibilities, and in the ER setting, it's important to know. We talk about causes from congenital, connective tissue, infectious, vasculitis, thromboembolism, neoplastic, and iatrogenic or traumatic, very nicely defined in this chart from the article. So let's do this. I want to talk a little bit more about technique. I want to show you a number of other examples. So let's take a few-minute break, get some coffee, and come right back. I'll see you in 5 minutes. Bye, guys. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.